Second session on spine instructional course. Our first speaker is Ian Zondagh, who's going to talk to us about why and how to classify neck injuries. Ian, thank you very much. Before he starts, just an announcement. We are recording this session, so if you've got a question, please come to the mic or wait for somebody to give you a mic if you are at the back so that it could be audible when you ask a question. Thank you.
Thank you, Prof, and thanks for organizers for inviting me. So I'm just going to try and go through some neck classifications and try and make some order. Right, so why do we classify neck injuries? I think it's because we try to make some order from nature's chaos in order to prevent further chaos when it comes to our neck injuries. So a spine injury classification system has to be clinically relevant, has to be reliable, and has to be accurate. Clinically, our classification systems are used as prognostic tools to determine the natural history of our outcomes. They're also used to guide treatment and further decision makings, and also to predict the possibility of complications. In the research or the clinical research arena, classifications are used to compare different treatments for similar injuries or similar treatments for different injuries. So if we look at neck injuries and classification systems, our CT scans are now being routinely used or performed during the diagnostic workup in the majority of our level 1 trauma centers. And increasing evidence supports the use of CTs of the spine rather than conventional radiography in the diagnostic workup. And moreover, with respect to clearance of the spine, we know that the CT is far more reliable than magnetic resonance imaging, and that MRI is currently not indicated to clear a spine in the absence of either neurological deficits or CT abnormalities. So just some sort of basic principles in management of cervical spine trauma. I think and I believe the content of our spine injury classification system should include injury characteristics of the vertebral column, the osseous structures. And I think for our spine injury patients, we must not forget our Asia score. The American Spinal Injury Association International Standards for Neurological Classification of Spinal Cord Injury has become standardized and has been routinely adopted classification for our spinal cord injuries. So we're specifically speaking about our spine, our vertebral column injuries. This doesn't project very well, but in essence, our classification system for spinal cord injury or spine injuries or spinal injuries form only a small portion of a large algorithm that gets down to treatment of our trauma patients. It includes our ATLS principles, the identification of clinical significant spinal injuries, severity measures, other comorbidities taken into account, and all of that with our classification systems then eventually end up in a treatment algorithm. So we mustn't be focused on the injury classification alone. So we're going to just start with our cranial cervical injuries. So our occipital condyle injuries, firstly, Anderson and Montesano published the classification in 1988 based on the fracture morphology of the condyle. The problem with this classification doesn't really guide our treatment and doesn't predict prognosis. But essentially, there's 3 types. We have type 1, We have type 1, which is a comminuted fracture of the condyle, which is stable. Type 2, which is a linear fracture through extending into the skull base, which is also stable. The only one of concern really is the avulsed fragment with potentially a rotational injury of our ala ligament. Another classification came out by Tully in 1997. They then based the classification on the stability of the entire craniocervical junction, where type 1 fractures include undisplaced fractures of the condyles that are stable, essentially not requiring treatment. Type 2 fractures are displaced condyle fractures with radiological stability of a craniocervical junction, also stable, maybe requiring a hard collar. And here the type 2B fractures are displaced condyle fractures with an unstable cradiocervical junction, which then requires either a halo jacket or a OC fusion. So what these do is they consider this type 2 fractures as a potential element of a more extensive injury, which is probably more common than isolated condyle injuries. So if you see an occipital condyle injury, the focus is on the occipital atlantal axial cone complex instead of just the condyle. Okay, we've gone through that. So the next group of injuries are occipital atlantal dislocations. The most common classification used for these injuries is the one presented by Trainellis in 1986. And his is a directional classification where he classifies type 1 dissociations as anterior, type 2 is longitudinal dislocations or dissociations, and 3 is posterior. These injury patterns and these classifications are nominal categories and they don't really grade the severity for us. Don't guide the treatment either. There's another classification that came out, the Harborview Classification, in 2001. And this makes more sense to me. This is 3 stages where stage 1 is an incomplete dissociation. Stage 2 is an occult dissociation, partially reduced with this rebound phenomenon. And stage 3 is an obvious occipito-atlantal dissociation with more than 2 millimeters of diastasis. Irrespective of the classifications, though, or the grading system, the recommended treatment for all of these injuries is a craniocervical fusion. So our next group of injuries is our atlas fractures. Isolated atlas fractures occur very rarely, and they only represent 1 to 2% of our spinal column fractures. Jefferson in 1920 was the first to bring out classification. He had 4 types: posterior arch, anterior arch, both arches, and then our lateral mass fractures. There's countless classifications brought out for this. There's Gerweiler brought one in 1976. He had 5 types of injuries. Landels and van Pettergem came out in 1988, and they had 3 different types of injuries. The most commonly used one, I think, is the Levine and Edwards, brought in 1991. And here they also isolate the posterior arch fractures, the typical Jefferson burst fracture, an anterior arch-only fracture, a transverse process fracture, and then our isolated lateral mass fractures. So this is the one which is most commonly used. Unfortunately, none of these classification schemes, all 4 or 5 of them have been mentioned, have been tested for validity or reliability, and none really guides the treatment or the prognosis for these injuries. The majority of the times, a cervical spine immobilization mode, either by a hard collar or a halo vest, is sufficient. And only in the coexistence of a transverse atlantal ligament rupture or long-term local instability at this level would require further intervention with internal fixation. So we can progress onto our transverse atlantal ligament injuries. So we know the diagnosis for this can be suspected from our lateral mass displacement on our AP views, where the displacement of the combined displacement of the lateral masses is more than 7 millimeters, as Spencer's rule, or by confirmation with a high-resolution MRI scanner. Dickman classified them in 1996 into 2 types of injury patterns, essentially a substance tear or a tear with a bony counterpart. Your substance tears, your type 1A and 1B, essentially do not heal without internal fixation, as they're ligamentous injuries. And your type 2 fractures are subdivided once again into type 2A with a lateral mass injury, and type 2B, where you have an avulsion of the tubercle for the insertion of the atlantal ligament. This type 2B injury is the one with a high risk of non-union and one that will probably require surgery. Okay, we progress on to odontoid fracture classifications. Classification most commonly used here is our Anderson and Alonso classification, 1988. There are others, but I think this is the simplest to remember. They categorize the fractures into 3 different types. Type 1, which is your apical dense fracture, which is exceptionally rare. type 2, base of the dents, and type 3 into the body of C2. Roy Camille then reclassified or added an extra step and classified the directionality of our fracture line of our type 2s, which is helpful in guiding our treatment. So we have an anterior oblique or a posterior oblique or a transverse fracture line. That's important when it comes to fixation techniques for odontoid fractures. Hadley also added an extra step where he added extra comminution at the base of our fracture. These are type 2As, and these are also more prone to non-union and often require surgery. So for odontoid fractures, external immobilization with a hard collar or a halo for 3 months, mainly for your type 1 and your type 3 injuries with a high union rate. It's our type 2s that are controversial. Type 2 fractures have a varying non-union rate, anything from 21 to 45%, depending on who you read. So, but external immobilization still remains the gold standard for the majority of our fractures. When you're looking at type 2 fractures, you can look at odontoid screw fixation. And here, Roy Camille's fracture discussion or the classification of the fractures into the shape of the fracture or the lines. A posterior oblique and horizontal fracture will be amenable to odontoid screw fixation, where a fracture line running in this direction will not be amenable to a screw fixation. And then the treatment then reverts down to a C1, C2 fusion. Okay, we can go on to Hangmans fractures. Classification most commonly used is was first described by Effendi in 1981 and then modified by Levine and Edwards in 1985. This diagrammatically here, type 1, 2, 2A, and 3, where we have an undisplaced fracture, displaced fracture with more than 3 to 4 mils, no displacement with severe angulation, and then fracture with our facet dislocation. There are other classifications out there. There's a Francis classification, a Jostin classification, but I think this is the one that we need to focus on and need to know. And the updated treatment recommendations for our pars fractures or our Hangmans fractures advocate surgery for our displaced fractures, our angulated fractures, where you have disc disruption at C2, 3, or where fractures cannot be aligned or achieved with external immobilization. The importance of these fractures is the additional or the type 2A fractures, where you have angulation at C2, 3 without displacement, where traction is prohibited for these fractures. For the rest, external reduction in immobilization remains the gold standard. So if we look at subaxial injuries, I'm going to try to get through some of their classifications. So our current common indications for surgery for our subaxial injuries include obviously failure of closed reductions, initially unstable fractures. That's where our classification comes in if you like to find out which patients are initially unstable. Patients that are dynamically unstable at a later stage with more than 3.5 mils translation or more than 11 degrees of rotation. Obviously progressive neurological deterioration, early mobilization in a neurologically compromised patient, patients with late complications, and patients with late instability and kyphosis. So there's a couple of classifications which were brought forward. I'm not going to spend too much time on these. Holsworth was the first to bring a classification in 1970. He classified them to 5 different groups, which is your flexion injuries, flexion rotation, extension, compression, and shearing. Then Allen came out in 1982 with his classification. This is a mechanistic classification. Once again, it's focused on the mechanism of injury. He had varying groups, all subdivided into different stages. He had a compressive flexion group, vertical compression, distractive flexion, compressive extension, distractive extension, and lateral flexion. This is helpful, I think, to understand the pathology, but it's not necessarily a good classification. Harris, 1986, a couple of years later, brought out another classification, also once again focused on the mechanism: flexion, flexion rotation, extension rotation, vertical compression, hyperextension, lateral flexion, and diverse, or not understood. So the first one that came out, I think that's worthwhile mentioning, is Vaccaro's slick score. This was published in 2007. And the sixth scale focuses on 3 different elements, both on our injury morphology. It's the first classification to include disco-ligamentous complex structures, and also it includes the neurological status. So the morphology gives a couple of points. You grade the disco-ligamentous structure, you get a couple of points, and the neurological status gets a couple of points. And essentially, patients with a score of 3 or less do not require surgery, and a patient with a score of 4 or more is operative. So the problem comes in if the patient ends up with a 4. It's not very reliable. But what's interesting when you're looking at all these scores that we mentioned, if you look at the comparison between Allen's and Harris's system, the sixth score, this new score, has got worse inter-rater and intra-rater reliability when evaluated properly. So there is a modification to the score. I don't think this is important. There was a modification brought out including MRI findings, but this was only brought out for distractive extension injuries, and I don't think it's of value at the moment. But it did improve the reliability for these type of injuries. So the next score that was brought out was done by the Spine Trauma Study Group. It was published initially by Moore in 2006, and then it was re-looked at by Anderson in 2007. And here it's an anatomical study using CT scans. They divide the spine into 4 columns, an anterior, posterior, and both a left and right lateral pillar. And they grade the scoring once again from a score of 0 to 5, and they add them all up and gives you a maximum score of 20. And Anderson did a study on this, and he recommended anybody with a score of less than 7 ended up being operated non-operatively, and anybody over 7 was operated on. The study was very small, not very reliable, but it was something done at least. So where do we sit at the moment? We think the SLIC system succeeds in fulfilling a lot of our requirements for a good classification system in the neck. It allows for quantifying both the severity from a radiological and a neurological perspective. Patel and them looked at all the different subaxial classification systems, and they felt that the Holdsworth, Allen, and Harris systems in essence compartmentalize injury into a variety of anatomic fracture patterns based on arbitrary inference of mechanisms that in reality may have had little to do with the acute actual injury. So those are mechanistic classifications, and it seems to be more on an interpretive classification where your SLIC system works on specific fracture morphology. So conversely, the SLIC system is based on information at hand rather than inference, and it seems to be the first classification system to abandon the inferred mechanism of injury, which probably makes it useful at the moment. It's simple, it's easy to use. There's still a lot of studies that have to be done. Hasn't been proven, the validity hasn't been proven, but it's probably the way to go at the moment. The new study by the Spine Trauma Study Group is currently too complex and difficult to use in clinical practice and seems to be destined for research at the moment. Thank you.